Welcome to the Health Information and the Law Perspectives from the Field interview series. Today we are speaking with Guy Collier, who is a partner at the law firm of McDermott, Will & Emery in Washington, D.C. Welcome, Guy.
Thanks, Jane.
Thank you so much for joining us today. Let's start by having you tell us a little bit about your current position and how it intersects with Health Information Exchange.
Sure. I'm a partner in the Health Industry Advisory Practice Group at McDermott in the Washington office, and my practice is exclusively healthcare and primarily large integrated provider systems and academic medical centers, including all components of the academic medical center. So I encounter health information issues frequently on the transactions that we're doing for our clients in those areas, and also discrete regulatory issues that come up from clients regarding health information, privacy, security, and things of that nature.
So in working with your clients on a variety of issues, you've probably witnessed a number of efforts, some of which you probably are successful, others which may not be as successful, to really transform healthcare delivery, the system, and also to greater enable use and exchange of health information. From your perspective, what are some of the most promising efforts to really transform healthcare delivery and to make greater use of health information?
Well, I think there are really three, and they all have the same purpose ultimately, which is to make care, not only make care more seamless, among providers, different provider locations and provider types, but also to generate meaningful data around quality and outcomes. And obviously something that we've been working on for, 25, 30 years at this point. But as we, head towards a system that's really, driven by quality and outcomes and not simply by, unit of service, this becomes more important. So what I see specifically are really three things. One is the widespread adoption of the electronic medical record by health systems across the country. Most of our clients fall into either the EPIC camp or the Cerner camp, depending on the nature of the beast. Academic medical centers tend to prefer one vendor over another, but it is very, very widespread at this point. Folks are really coming out of the implementation process, but and they've spent tens of millions of dollars, hundreds of millions of dollars on this process. But it's a good thing. When you go into most academic medical centers today, they've got a very fulsome health IT platform, and everybody is using handhelds. And at least within that system, people can speak to each other real time. So I think that's very encouraging. A couple of other things: the ability to link community physicians to the health IT platform through a variety of means. When health systems, hospitals, academic medical centers purchase providers, when they employ providers directly, or when they structure contractual relationships, professional services agreements, and other sorts of contractual relationships with the individual practitioners, they're able to step out the health IT platform to them, subject to some of the regulatory constraints we'll talk about, and I think that's tremendously helpful. And then the third area is really in the ambulatory clinic space, the community health center, federally qualified community health center, and non-federally qualified, and particularly some of the initiatives around, linking community health centers with each other in a given geographic area. These are truly the safety net providers in an area. And we were lucky enough to work on an initiative right here in D.C. probably 4 years ago now with the D.C. Primary Care Association to implement a sort of a citywide electronic medical record platform across the primary care providers, or at least the health clinics. So I think that is another very encouraging sign. So I think those are the things I see on the provider side that give me some degree of encouragement.
That's wonderful, and obviously those have led to a number of successes in a number of areas. Obviously, as you've been working through these issues with your clients, I'm sure you've encountered some challenges or barriers to these reforms. Could you share with us what you think are some of the most significant barriers, legal or otherwise, to pursuing these reforms?
Right. Well, I think the The most significant barrier now is the inability to achieve full integration, to link community primary care physicians, community health centers into a true integrated system of care. It's still a very fragmented system. We may link the academic medical center components together. We may link, a given nonprofit hospital system's facilities together. We may get their physicians into the system, but for the physicians not in the system who are out in the community delivering primary care, or those community health centers who aren't, fully electronic nor fully linked to the neighboring hospital systems, it's still a fragmented care. I can go to my provider, my primary care provider at the University of Missouri Health System, and it's terrific because he and all of his colleagues and every component of the University of Missouri is linked. So they're on this wonderful electronic platform. I can access them by email. They can refill prescriptions. We can do everything electronically. But as soon as I step outside that system, I'm really on my own in terms of, other providers who are not part of the network, other care sites who are not part of the network. They don't link. There's no way for them to link. So the biggest barrier I see, Jane, is really the continuing fragmentation.
And obviously, thinking about these issues from a legal perspective, I think there are some ways that the law can help facilitate more effective use and break down some of these challenges, particularly fragmentation that comes from the inability to fully integrate or be interoperable. In some ways, there's perceptions that the law can actually hinder these efforts. So in your experience, I guess it's a two-part question. What role does the law play in hindering these efforts? And on the other flip side, what role does the law play in facilitating these efforts?
Well, I think that's a great question and a complicated question. I think the primary barrier legally, I would say it's not HIPAA. I think that HIPAA has been, was long overdue, and it's a very, very important set of protections, both in terms of privacy and security. And yes, it was added cost to all providers, but, there's so many common sense ways through the, permissible uses under the statute, through appropriate authorization and consent to really work around HIPAA. So I don't see that as a barrier. I think HIPAA is a good thing, has been a good thing, continues to be. But some of the regulatory statutes, Jane, that you and I have worked with for years are still problematic, particularly when you're going outside a closed system to step out your health IT platform to independent community physicians who may be voluntary members of your medical staff but are not employees. We still face, there are really two issues. The cost is tremendous. And I think cost is a significant barrier across the entire spectrum here. But we've got the regulatory barriers that come out of the federal program anti-kickback law and the federal ethics and patient referrals law, which quite well, prohibit remuneration to a physician unless it fits a designated exception under the ethics and patient referrals law. So, with the attempted relief under those statutes a few years ago where basically the feds tried to loosen those requirements and, make accessibility to a provider's health IT platform not prohibited here, but still requiring a pretty significant copay, 15% if I recall. It's still an impediment. Those statutes are still an impediment, and the cost itself is an impediment to really stepping this out to the primary care. So again, if you're an academic medical center and you've got 600 captive employed faculty practice plan physicians, that's fine, that works well. But if you're an open staff model, as many of my clients are in the academic space, and you happen to have 2,000 physicians who are not part of your faculty practice plan, you may get your health IT platform out to some, but likely not all of them. So again, I think those regulatory statutes really have not given us the sort of relief under those statutes that would be necessary to achieve, full integration here.
And even with the continuation of those, I would believe it was last December, obviously there's hope that they will give greater relief, particularly to long-term care and some of the sectors of the industry that haven't increased adoption of electronic health records like hospitals and physicians.
Right.
But I agree with you, it's still limited.
Yeah, and that's a great point. We didn't mention long-term care, the whole post-acute sector, whether, freestanding outpatient rehab, long-term care, skilled intermediate long-term care facilities, they are in many ways largely outside the system, and that's where a lot of care, particularly in the long-term care setting towards the end of life, a lot of care happens. So yes, they're not nearly as integrated as we would hope.
So looking ahead, understanding obviously we've talked a lot about promising efforts, some barriers. When you're working with your clients and you're thinking about furthering, reform of the delivery system and greater use and exchange of health information, particularly I think both across the system as you were talking about, but also sort of breaking down that barrier of being able to share outside the healthcare system or a particular healthcare system, what strategies would you recommend or do you think hold the best merit for really advancing delivery system reform through greater use of health information?
Well, that's a loaded question and a great one. Again, we see our provider clients really going in, full bore for this, and they have spent enormous sums of money, and they take, a year and a half, 2 years to implement, and some have had, significant financial impact on those systems just because of the sheer magnitude of the cost here. But to really wrap in the disparate elements, the, independent physicians who are not employed, the alternative, site providers, diagnostic imaging, ambulatory surgery, long-term care, freestanding rehab. I think it takes a couple of things. It takes statutory mandate to do that, but it takes money. And I think we're looking at funding from the states as the Medicaid provider in most states, and we know from health reform what a difficult task that is, since we had many states opting not to expand Medicaid because of the fear of cost escalation. But we need, contribution from the states. We need contribution from the feds, enhanced hard dollars, maybe flowing through the Medicare program to incentivize providers to, get into the game, the electronic health information game, and I think from commercial payers as well, who have their whole set of, their own set of concerns under health reform with, what the exchange business will look like, and can they maintain appropriate reserves and margins and so forth, but I think they've got to get into the game financially. So I think we need to see, not to simplify it, but I think in many ways this is all about the money. And I think we need to see a real infusion of funds here because this is very expensive stuff. And it's difficult enough for hospitals, but when you step down to the community health center or the long-term care provider or the freestanding rehab clinic, this stuff is wildly expensive and maybe prohibitive. And so I think we need, much more in the way of financial resources.
That's really helpful. I think we've explored that from a number of perspectives. It's interesting, though, to focus on the financing. We obviously think a lot about sort of the legal policy challenges or barriers, but at the end of the day, this is not an inexpensive proposition, and the funding has been, while there's more funding than there historically has been, it's still limited in nature, and as you said, in some situations even comes with restrictions in terms of how it can be used or how tools and resources can be shared. So that's really helpful.
Yep, and I think, just to sum up, Jane, I think if you take a step back and look at the environment now, we have these conflicting pressures because our clients are consolidating like crazy. They are acquiring each other. They're merging academic medical centers, getting out of the clinical business, staying in the academic and the research business, but, getting out of the clinical business. So we see tremendous consolidation, and in large part it's driven by fear of the unknown, fear that, under shrinking Medicare and clearly shrinking, if not shrunken, Medicaid dollars, it's going to be a very difficult environment for folks. So we see combination, we see this need to consolidate and a fear of shrinking reimbursement, and at the same time, those very fears, prohibit people from maybe putting the amount of resources into this that they need to do. I mean, folks look at things like days of cash on hand, and when a health system drops from whatever the number is, 230 days cash on hand to 100 days cash on hand, they are nervous, and the bond rating agencies are nervous. Everyone is nervous. So, even though this is exactly what they should be doing, those same pressures that are driving consolidation sometimes, lead them to back off, from a wholesale adoption. And again, it's even more acute in the case of these alternate site providers we talk about who just don't have the capitalization to do that. One footnote, we do see some significant private equity activity with alternate site providers and even specialty physician groups again. And with that, private equity play, we may see some, capital dollars free up for some of these providers. But right now, they tend to be clustered among the more lucrative specialties, as you might imagine, things like anesthesiology.
Wonderful. Well, this has been incredibly helpful. We really appreciate you spending time with us today.
Well, my pleasure. You guys are doing great work, and it's an absolutely fascinating area, and it's a large hill, given the fragmentation of our healthcare system and number of providers and number of payers. It's a daunting task, as you know.
Yes, it is. Wonderful. Yep. Well, thank you again.